Hi, I'm Pat Garrity, an instructor of medical laboratory technology.
And I'm Jerry Walters, hematology supervisor in a clinical laboratory.
Jerry and I saw a need to standardize the way we identify and describe different white blood cells on routine differentials. One of the reasons is the recent changes in health care. Blood work on the same patient is performed at various facilities instead of always at one laboratory. Because of this, inter-laboratory standardization is essential.
It is also important to have simple standard criteria to assure consistency within your own laboratory. The current trend is towards more techs with generalist abilities, which means fewer specialists.
In this video, we're going to address routine findings on differentials. In the documentation provided with the video is a procedure for white blood cell morphology reporting. This procedure can be put in your laboratory's manual. The first part of this procedure addresses the evaluations needed to be performed before actually differentiating the various white blood cells. These are slide quality, area to count, and number of cells to differentiate.
The most important thing to start with is a well-made smear. If you have a lousy slide, you're going to get a lousy result. It has nothing to do with your abilities as a tech. A poorly made smear is going to have a poor distribution of white cells. Now, obviously, you can hold the slide in front of your face and tell whether it's poorly made, but they should also be examined microscopically at a low power, preferably 10x, to see if they are acceptable. A well-made smear, like the one you see here, will have 2 to 3 times as many white cells per field in the far feather edge as you will see in the body of the smear. If the feather edge has more than 5 times the number of white cells per field that you see in the body of the smear, as you see in this slide, it is not acceptable and should be remade. It obviously follows that you also need a good stain. A well-stained smear will have red cells that are the proper color, as well as clear, distinct cytoplasmic and nuclear detail in the white cells. A poor stain, such as this one, will not only make it difficult to differentiate cells, but may make it impossible to detect abnormalities such as toxic granulation.
Choosing a good area to count is essential to ensure acceptable results. This slide shows a good area to count. At first glance, it looks odd, but that is because of the elevated platelet count. Don't let that throw you. The red blood cells are slightly overlapping, making an even background. Once you find a good area under low power, then you must change the objective to either 50x oil or 100x oil. If you have 50x oil, it is acceptable to perform differentials under that power. If you don't, then you must use 100x oil. If you use 50x oil, you must have the availability of using 100x oil when you have questionable cells to identify. There are 2 recommended ways to move the slide when differentiating white blood cells. Both of these methods are referred to as the battlement method. I refer to moving the slide as driving the microscope. The battlement method, which we recommend, is difficult to get used to. Driving the microscope is difficult because there is a hazard of moving too deep or too thin repeatedly. The other method, sometimes recommended, is easier to perform because driving is so much easier. But many feel cell distribution is not as representative. We recommend the first method, but realize it may be difficult to get used to. This slide shows a lymphocyte in a good area. The RBCs look good too. This slide shows a lymphocyte in an area way too deep. The lymphocyte is all balled up and very difficult to identify. Other cell types will do the same thing. This slide shows a lymphocyte in too thin an area. You can see how this lymphocyte is too spread out, making the nucleus look abnormal with so much visible parachromatin. Some of it almost makes the cell look like it has a nucleolus. Some authors will say that a certain number, such as 150 to 200 red blood cells, are necessary for a good area to count. This is good if the patient's red count is normal. Once the patient's red count is outside the normal limits, then this is not an acceptable way to evaluate a slide. That's why it's so important to know when you have good white cells.
Historically, we have always started with a 100-cell differential, and we believe this is still true if you are looking at every slide. When certain abnormalities are encountered, you should proceed to do a 200-cell differential. We have indicated those instances which require a 200-cell differential in the procedure included in your documentation manual. However, we also realize that this is the 90s, and if you are using an instrument with an automated 3-part or 5-part differential to screen your samples, we believe a 200-cell differential is required on those samples that fail your screening criteria. By definition, those samples have already been identified as potentially abnormal. And you have to remember that the 100-cell differential has very limited sensitivity in detecting abnormalities.
We are now going to talk about the various white blood cell types seen on routine differentials. The procedure we included with the documentation lists these cells, the recommended way to report them out, and conditions under which we report and recount. We are going to begin with the neutrophil, and first the segmented neutrophil. After we have given descriptions of both the seg and the band, we will then talk about the differences. The segmented neutrophil is lobulated and the lobes are connected by a filament. Sometimes, because the nucleus is folded, this filament is hidden. This neutrophil is easily identified as a seg because the filaments are so obvious.
The band neutrophil has a nucleus which is indented more than half the width of the entire nucleus. There is no visible filament. The nucleus may be deeply indented, but the connecting bridge or strip between the two portions of the nucleus still has visible chromatin. The cell you see here is a classic band. Unfortunately, all bands are not picture perfect. Take the Grateful Dead, for instance. That is not a pretty band. No, seriously, this leads us to the problem of band-seg differentiation that has plagued us for years. Differentiation of bands has very poor reproducibility because criteria often varies and differentiating them from segs is often subjective. We have placed far more faith in the band count than we should. Repeated studies have shown the band count to have very poor sensitivity as an indicator of infection. And other findings such as fever, neutrophilia, toxic changes, or leukocytosis have better sensitivity. An obvious indicator of what we hope is the future demise of the band count is the fact that the College of American Pathologists is no longer including band identification in its proficiency testing. The CAP specifically cited the poor reproducibility of band identification in announcing this change.
Our recommendation is to group bands and segs together and report them out as neutrophils. There are some well-known laboratories that have been doing this for several years. We have included in the bibliography of the documentation some articles that clearly address this issue. If, however, you are unable to abolish the band-seg differentiation, we are recommending adopting the when in doubt, call it a seg criteria. Once your laboratory establishes a criteria, do not change it. Stay consistent. Now we're going to look at some cells. Both of these cells are segs. One of the cells at first glance may appear to be a band, but on closer inspection there is a definite possibility of a twist or fold. Once there is a question, it is a seg. The other cell is more easily identified as a seg because of its folded or twisted appearance.
Both of these cells are twisted, suggesting there may be a suspected lobe at either end and/or hidden filament. Thus, both cells are segs.
At one end of this cell, the lobe is folded over, so it is a seg. There is an area, though, that shows a good example of an isthmus with chromatin in it. If there had been no twisting and folding, then this cell would have been a band, but since there is twisting, it's a seg.
The nucleus of this cell is twisted, and there is a suspected lobe at the bottom portion. We call it a seg. This nucleus is folded back on itself and appears twisted. There may be a hidden filament, so it is also a seg.
Now we would like you to take a look at this cell and figure out what you would call it using our criteria. Jerry and I have had some friendly discussions about it.
You call that friendly? It wasn't really very friendly. At which point it dawned on us if we were arguing about the cell, there must be doubt, and it was a seg. The nucleus appears twisted right here.
I convinced Jerry of that.
I gave up. The next cell we're going to talk about is the metamyelocyte, which technically, I guess, is not a common finding, But depending on the population of patients you're dealing with may not be uncommon. If you have a large population of OB or post-surgical patients, you may see them more frequently. The metamyelocyte has a central or eccentric nucleus, which is indented but less than half the width of the entire nucleus. The cytoplasm is pale blue and has specific granules. These two cells show the difference between the band and metamyelocyte. The nucleus of the band is indented more than half its width. The nucleus of the metamyelocyte is also indented, but certainly less than 1/2 its width. The lack of granulation in these cells is not typical, and we're going to talk about this in a few minutes. This cell is more typical of a metamyelocyte. The nucleus is slightly indented, the cytoplasm is pale blue, and contains numerous granules. This cell is also a metamyelocyte, but a little more immature. The chromatin pattern is a little finer, but the nucleus is indented. And this final group of cells shows the difference between the metamyelocyte and a myelocyte, which is the center cell. The chromatin pattern of the myelocyte is more immature, and even though the nucleus is flattened on one side, there is no indentation. Some may call this a late myelocyte, and others may call it an early meta. You have to remember that these cells develop in a continuum. A cell is not a myelocyte 1 second and a metamyelocyte the next second. What is important is to maintain consistency. Our recommendation is to identify the cell as a metamyelocyte when the nucleus has an indentation, however slight. The third cell in this field is a SEG.
Are you sure?
Sure, as soon as you ask me, I'm sure. Because you made me doubt, I'm sure.
Okay.
When there's doubt, it's a SEG.
I think the cell does have a twist in it. The important criteria for differentiating hypersegmented neutrophils is that the nucleus has 6 lobes. If there is a question or doubt that it is actually 6 lobes and maybe only 5, then we recommend not calling it a hypersegmented neutrophil. These cells are present in nutritional deficiencies, and some authorities think it is the first abnormal finding in these deficiencies. These cells are counted as a separate cell type and reported as a %. This cell obviously has 6 or more lobes. The other concern when counting lobes is not to count the drumstick as a lobe. In this cell, if the drumstick were counted, then the cell would be a hypersegmented neutrophil, which would be misleading to the physician.
Hyposegmentation is an abnormal decrease in the lobulation of the neutrophils. These are mature cells that have failed to lobulate normally. The cause of hyposegmentation may be inherited, as in Pelger-Hewitt anomaly, or may be related to a drug therapy. The importance of recognizing this abnormality is to differentiate it from a left shift. If you are still calling bands, in cases of hyposegmentation, we recommend you include this comment. Neutrophil morphology is suggestive of nuclear hyposegmentation, not a left shift. This cell is typical of a hyposegmented neutrophil. On closer examination, it shows the classic dumbbell morphology seen in Pelger-Hewitt anomaly and mimics a band. If you suspect hyposegmentation, it may be helpful to look at the eosinophils. They will also show hyposegmentation of the nucleus, as does this eosinophil.
We are now going to discuss toxic changes of the neutrophil. These findings are sometimes more indicative of infection than other differential findings. The 3 types of toxic changes are toxic granulation, degenerative vacuolization, and Döhle bodies. Toxic granulation is caused by an increase in the number of cytoplasmic primary granules. The finding is very dependent on the quality of the stain used. Because of this, and because of so many other variables, we recommend reporting toxic granulation as being present instead of somehow arbitrarily trying to grade it in pluses. This slide shows toxic granulation in the neutrophils. The amount of the toxic is not important, but the number of cells with toxic granulation is. Toxic granulation is reported any time more than 10% of the neutrophils have it. These cells have a significant amount of toxic granulation. Again, we would report it as present if more than 10% of the neutrophils displayed it. It is difficult in the beginning to stop evaluating the intensity of the granules. To quickly calculate the 10% number, all you need to do is take 10% of the total number of neutrophils. If differentiating bands and segs, you need to add them together and use that number. Anyway, you take the total number of neutrophils and multiply by 10%. That is the minimum number of cells with toxic granulation you have to report it as present. In this case, you would need at least 8 of the 80 cells.
Degenerative vacuoles are small holes or vacuoles in the cytoplasm of the neutrophils. They are the result of phagocytic activity by the cells and are considered a toxic finding. Degenerative vacuolization should be reported as present if it is seen in more than 10% of the neutrophils. This neutrophil has degenerative vacuoles, as does this neutrophil. The heavy toxic granulation in this cell may almost obscure the vacuoles. You have to look closely. Döhle bodies are aggregates of rough endoplasmic reticulum that appear as blue spots in the cytoplasm of the neutrophils. Detection of Döhle bodies is very dependent on the quality of your stain, and Döhle bodies are sensitive to EDTA and may disappear over time. So if you're working with older samples, you may not see them frequently. Döhle bodies should be reported as present if any are seen. Both of these cells have toxic granulation, and one has a Döhle body right here. It is not uncommon to find multiple toxic changes in a single cell.
Hypogranulation of the neutrophil can be an important finding, indicating degranulation of the cell, which occurs in some infections and some myelodysplasias. The problem with evaluating hypogranulation is staining quality can affect how the granules appear. If hypogranulation is suspected, a new slide should be made and stained with a new batch of stain. If there still seems to be hypogranulation of the neutrophil present, the slide should be referred for further review. In this slide, there are no granules in the neutrophil. However, on closer inspection, the basophil also appears washed out, which may indicate poor stain. You can see why it is so important to confirm, since so often it is only a staining artifact.
Eosinophils are distinct and easily identified because of their large, marble-like red granules. Unless there is moisture in your stain, then the eosinophils may have a washed-out look like this, or worse, and may be difficult for the novice to identify. Basophils are also easily identified by their numerous, large, dark staining granules. Even in cases of heavy toxic granulation in the neutrophils, as you see in the cell on the left, the basophil on the right is easily identified, if your stain is good. However, if there is moisture in your stain or fixative, the basophil may look like this. This would be difficult to differentiate from toxic granulation, especially if it occurred sporadically throughout the smear.
Now we will review lymphocyte morphology and differentiation. There are 3 types of lymphocytes we will be discussing: normal, stimulated, and abnormal. Normal lymphocytes come in a variety of sizes, primarily either small with scanty dark cytoplasm with a nucleus about the size of a red blood cell, or large with more abundant cytoplasm. Some of the large lymphocytes may have some azurophilic granules. I'll talk about them shortly. This lymphocyte is a typical small lymphocyte. The nuclear chromatin has a smudged appearance. If all lymphs look like this, differentials would be easy. This lymphocyte is large and has more cytoplasm, although not as much as some large lymphs. This lymphocyte is also a large cell, but it contains a number of azurophilic granules. Large lymphocytes with granules have caused quite a stir in the hematology lab in the past few years because of their possible clinical significance. We recommend reporting them as present only if there are more than 15% present of all lymphocytes. These slides should also be forwarded for further review when they are reported.
One type of stimulated lymphocyte are those we call reactive. Reactive lymphocytes are large polymorphic cells with abundant blue cytoplasm, which tends to darken at the contact points with other cells. Reactive lymphocytes are more sensitive to the degenerative effects of EDTA than our normal lymphocytes. Reactive lymphocytes should be reported as a separate cell type in %. This reactive lymph has the typical abundant blue cytoplasm, which is deeper blue at the contact points with the red cells. This is a dying or even dead lymphocyte. These dead cells can be seen when reactive lymphocytes are exposed to EDTA. Their presence should alert you to the probability of reactive lymphocytes. Another type of stimulated lymphocyte is the plasmacytoid lymph. Plasmacytoid lymphocytes have a deep blue basophilic cytoplasm and coarsely clumped nuclear chromatin. The chromatin pattern in a true plasma cell, which you see here, is more distinctly clumped with visible parachromatin, these clear areas. The cytoplasm is usually not as deeply basophilic.
Abnormal lymphocytes are found in more pathological conditions than the stimulated lymphocyte. These cells have abnormal chromatin patterns and other nuclear abnormalities. These cells should be reported as a % of a separate cell type. When reported, the slide should be forwarded for further review. This is a reactive lymphocyte to use as a reference point. This is an abnormal lymphocyte. When first viewing this cell, the thought of it being reactive comes to mind because of the way the contact points seem to hug the red blood cells. But when looking at the fine structure of the chromatin, you then know it is not a stimulated lymphocyte, but an abnormal one. These cells are again abnormal. The chromatin is very fine and immature, and there are nucleoli present.
The last cell type we're going to discuss is the monocyte. The monocyte has a delicate, lacy chromatin pattern and gray-blue cytoplasm, which is often described as resembling ground glass, like any of us have a clue what ground glass looks like. The vacuolated cytoplasm you see in this normal monocyte usually makes it easy to identify the cells, but these vacuoles are the result of exposure to EDTA. In direct finger stick or heel stick smears, the monocytes are not typically vacuolated. Monocytes can also mimic other cells, as in this monocyte, which has some lymphoid characteristics. Although the chromatin pattern is not lacy, it does not have the characteristic smudged chromatin pattern seen in the lymphocyte nucleus. This monocyte mimics a band because of the shape of the nucleus. The cell could be misidentified if your stain is poor. You need to shop around and see how the other cells are staining.
We now need to talk about some other structures which may be seen while doing a differential. These may cause inaccuracies. These concerns are necrobiotic cells, disrupted cells, and cells other than leukocytes. The first of these is necrobiotic cells. These are cells which no longer are living cells. The most frequent cause of these cells being present is that the sample was old or the slide wasn't made right away. These cells cannot be reported since they are not identifiable. This cell is typical of a necrobiotic cell. There is absolutely no nuclear detail left. This cell also is typical of a necrobiotic cell, but the hazard with this one is if the staining quality is poor, some less experienced people may confuse it with an NRBC.
Disrupted cells include basket cells, smudge cells, and plain old broken cells. Basket and smudge cells are not truly cells, but are nuclear remnants of cells. Some references link basket cells, like you see here, to disrupted neutrophils, and smudge cells, seen in this smear, to lymphocytes. However, this may not always be true, nor is it important. This case of chronic lymphocytic leukemia has both basket and smudge cells, although CLL is more often associated with smudge cells. The importance is to recognize these as cellular remnants. These were intact cells when the white cell count was done. If you see more than 10 of these disruptive cells per 100 white cells, they should be reported as the number seen per 100 white cells. You also need to remember that disrupted cells will affect the accuracy of your differential. And if you see more than 10 of these per 100 white cells, the smear should be remade using an alternate method. One inexpensive method is to add albumin to a small portion of the blood and remake the smear. The albumin will protect the cells during smear preparation. There are also available small instruments which make a monolayer smear without trauma by rapidly spinning a slide after a drop of blood has been applied. Broken cells can be seen in older samples or when excessive pressure has been applied during smear preparation. These are not typically pathologically fragile cells, although toxic neutrophils can become more fragile with time. Broken cells in many cases are still identifiable, as is this broken basophil. If you can still identify the cell, it should be included in the differential. Chances are we broke it. Some broken cells, like this one, cannot be accurately identified. Again, if you see more than 10 of these per 100 white cells, the smear should be remade using an alternate method.
Cells other than leukocytes include NRBCs and megakaryocytes or megakaryoplasts. These cells, when present, are reported as the number per 100 WBCs. If there are more than 5, then these cells can affect the white blood cell count. To correct the white blood cell count, the formula to use, along with an example, is in the documentation manual for you to refer to. With the automated instruments available today, it is not always as straightforward as the formula appears. Because of these instruments' ability to size and discriminate various populations of cells, sometimes if the NRBCs are small, some or even all of the NRBCs are not included in the automated instrument count. Before using this formula to correct for NRBCs, each institution must know exactly what the white blood cell count on the instrument actually is. Many times when automated instrumentation is used, an alternate, possibly even a chamber count of the total nucleated cell count must be performed and plugged into the formula. This cell is an NRBC. As you can see by the size of this cell, it may or may not be counted, depending on how the instrument discriminates by size and structure. This cell is a rare finding on a differential smear. It is a megakaryoblast, and this is a nuclei of a megakaryocyte. Since these are not a type of white blood cell, if they appear in any significant number, they can affect the white blood cell count.
We know we have not covered every abnormality you're going to see on your peripheral smears. We'd be here for hours if we did. But we hope we have given you a tool to help standardize your laboratory in reporting the things you commonly see in white cell morphology. And if not, at least you get out of work for a half hour to watch this video.
Or class, I suppose.
You can tell who teaches. And in closing, we want to remind you that even white cells have a heart.